talking about TGA, about the post-op care, the immediate post-op care. This is going to be amazing, I'm sure. The first part was very good when he talked about the transitional physiology of TGA. It was really useful for all of us who work on the intensive care unit, and even for those who are advising the moms before the babies are born, so how things are going to develop. It's very, very interesting. So if you didn't have the chance, take a look on the YouTube channel. And on the 29th, we are going to have another fetal series. We are going to talk about fetal interventions. This is going to be very nice. 3 amazing speakers going to tell us what is the state of art on cardiac interventions on the fetal life. Please join us on that. And now we are going to have Dr. Fallot, and his series continues every month. So please join us on that. Norman, thank you very much again for being with us.
My pleasure. Can you hear me?
Very well.
Okay. So, good morning, everybody. I'm going to be discussing the morphological correlations between the echocardiographic presentation of transposition complemented by the pathological or morphological descriptions of this. Today's Précis is a part of a series I have prepared through this website, www.md1world.com, and the chapters are available for downloading there as well, together with a full complement of descriptions. Now, we should always begin by discussing what is tetralogy, and I think we all know the definition of tetralogy. So here are 2 specimens, one from Diane Spicer and one from the Mayo Clinic, which I think highlight all the features. Here we can see the interventricular communication or ventricular septal defect with the aorta overriding the space of tissue which subtends the defect. And here on the right is a cut. This is a 4-chamber cut, and this is a subcostal coronal equivalent cut. And what we see here is this classical feature of tetralogy, which is the deviation of the outlet septum, narrowing the ventricular outflow tract. And when we ask people what is the definition of tetralogy, they always say that there's a deviated outlet septum with subpulmonary stenosis as the primary. There's aortic override of a ventricular septal defect, and the right ventricular hypertrophy is separate. And as you know, this was discussed and discovered by Dr. Etienne Louis Arthur Fallot in the previous century, in the 1800s. And he was a coroner in Marseille, and he wrote 4 papers on the subject. But he called it La Maladie Bleue, the blue disease. And in my travels, I came across another Dr. Fallot. And this Dr. Fallot, it was at the time a resident in Seattle, Washington. And he said, I am the great-grandson of Dr. Etienne Louis. And he said, we look just the same. So let's just go over the genetic similarities of the great-grandson for the father. Here is the widow's peak. Here is the anti-mongoloid slant to the eyes. Here are the classical gloppy ears. Here is the pointy nose. And here is a bifid chin concealed by Dr. Etienne Louis' beard. So what we can conclude from this is that we should always remember that tetralogy has genetic components to it, and particularly the 22q11 minus disease, which we know is the DeGeorge syndrome, velocardiofacial syndrome, etc., etc. Now, who just called this tetralogy of Fallot? Well, it was Maud Abbott, who in 1924 put out the first atlas of congenital heart disease anomalies. She is a fiery and wonderful person, and she could read French, And so she read the 4 papers in Marseille Medical that Etienne Louis had actually presented. And who is this gentleman? Well, this is Mr. Stenson, Nilus Stenson, a Catholic prelate from Germany, who was also a geologist and a scientist, and who was presented with a heart like this in an abortus fetus and said there's only one abnormality, and that's this deviated outlet septum, which is the fundamental of tetralogy of Fallot. And if this was clay, we could take this and close the aorta to the left ventricle, relieve the subpulmonary obstruction, and of course the right ventricular hypertrophy would be separate. Unfortunately, we cannot do that, but this also is called the monology of Stenson. And Niles Stenson lived from 1638 to 1686, a good 150 years before Etienne Louis. So just one diagram to show the normal heart with aorta, pulmonary artery, the true subpulmonary infundibulum, the Y of septal band, or the, as Dr. Van Praag's people would call it, the Christus supraventricularis, the septoparietal trabeculations, and the membranous septum. And in tetralogy, this drawn by Diane Spicer, my colleague in this venture as well, shows the position of the ventricular septal defect cradled in the arms of the septomarginal trabeculation. The outlet septum is malaligned in its development and deviated, so the plane of this is completely different, and the obstruction is related not only to the anterior and superior or cephalad deviation of the outlet septum, but to these muscles over here, which are the septoparietal trabeculation, and which the surgeon actually will cut across. So here we start our venture. And the venture will have, firstly, a scan plane across here, which will show us the position of the scan plane on the heart, and then the subtended scan plane, all with labels. And I'm going to not say this anymore, but first the scan plane will disappear. Then we will see the labels, as we see here, tricuspid and mitral valve, the ventricular septum with aortic override, highlighted by these little arrows, and the left atrium. And this is heart is oriented to compare to the echocardiogram over here. And so the labels disappear. There's what we see. And you can see that this defect is a perimembranous extension, although it's an outlet defect, because the tricuspid, the aortic, and the mitral valves are in fibrous continuity, one with the other. Then the echocardiogram will move. Then you will see the echo unadorned. I have in this patient an additional Doppler color flow to show not only the aortic override, but the unusual right to left ventricular shunting that is occurring in this patient. This is not the usual pattern of shunting in tetralogy of Fallot. It is usually from the right ventricle directly into the aorta. And then the labels will disappear. And for those of you that are looking and viewing this on a cell phone, the images are magnified so that you can get a better look at this. Here is a patient with the apical 5-chamber view, which shows the aortic override of the ventricular septum on another specimen. And the echocardiogram in this apical 4-chamber view shows the aorta overriding the ventricular septal defect. And the green arrows here highlight the flow of the blood directly from the left ventricle and from the right ventricle into the aorta, which is the more usual pattern of the distribution here. And then again, the zoom to allow you to look at the comparison between the echo specimen and the morphological specimen. Here is a subcostal image of a tetralogy of Fallot, and you can see this cone of tissue which subtends the space underneath the aorta and above the ventricular septum. It is a 3-dimensional space, but the surgeon will replace this here. This is the embryological secondary interventricular communication. And here is the area of what we call the ventricular septal defect, which is not really the defect, but is the area that the surgeon patches. And there's the specimen, this one obtained from Professor Anderson's collection, as he is a co-author on this volume with me. And here is the echocardiographic example of this as well. And we can see in this not only the override of the ventricular septal defect by the aorta, but also the aorta arching to the left side and keeping underneath the curve the pulmonary artery root. Here, once again, and I think most importantly, is an example in the subcostal coronal cut, which shows the deviated outlet septum. Here is the ventricular septal defect, anterior leaflet of the tricuspid valve, the fibrous continuity between the ridge of tissue called the membranous flap underneath the ventricular septal defect, the deviated outlet septum, the pulmonary valve leaflets, the so-called third ventricle with the right ventricular outflow tract, and the squeeze that occurs between the septoparietal trabeculations and the anterior and superiorly deviated outlet septum. And this actually matches quite beautifully with the echocardiogram. And I've superimposed color flow on top of the black and white image, so you can see this little entrance into the infundibulum here and the tight pulmonary trunk, as well as the fact that there's more flow coming from the pulmonary trunk into the aorta, suggesting that this was really a patent ductus which was supplying the pulmonary flow. No surgery had been done on this patient. You can see from the size of the centimeter scale marker that this is a neonate. And then zoomed in for you to get one final look at this beautiful comparative image. Now we can also cut the apex of the heart off and look from below upwards, and we see mitral and tricuspid valves, the ventricular septum, the arrows highlighting the position of the aortic root with its fibrous continuity. And this almost is a double outlet. There's about 70% override, but this is really Tetralogy fellow because of its phenotypic features, although double outlet and tetralogy may exist in the same specimen. And here is the echocardiographic correlation from a subcostal sagittal cut, showing again the aortic override, the ventricular septal defect, the deviated outlet septum, and the so-called third ventricle, as it used to be called, which is a feature of Tetralogy fellow. So we'll progress through this now as we look at these examples. Really quite excellent correlation between what is seen morphologically and what you can do with your echocardiographic transducer. And in talking about the ventricular septal defect, we've talked about the aortic override to a greater or lesser degree. The right ventricular margin of the conus space subtended by the overriding root is defined as the area to be closed by the surgeon. Now, one thing that is a sort of a bombshell, in most cases, the interventricular communication has an extension into the perimembranous area, exposing the conducting tissue, and we'll go and show you that to do the surgeon's life. And in other cases, there is a well-marked posterior inferior rim, such as is usually seen in common arterial trunk and in double outlet right ventricle, that protects the conductant axis. So let's look here at a specimen, and the first thing that we put in here is the axis of the conducting tissue. And you're looking here at the aortic at the interventricular communication, and we see the septal band here, and we see the other part of the septal band subtending the V of the VSD here. And when we take the echo cut away, that we see here in this parasternal short axis, we can see that there is a deficiency of muscular tissue in this area, so that the conducting axis is exposed to the surgeon's knife. And I think as an echocardiographer, that's one of the important things that you can tell the surgeon before he goes in. And here is an echocardiogram. We see the right coronary enter the right coronary cusp, the left coronary cusp, and the non-coronary cusp. And the aorta is in fact dextro-rotated around from all of these issues. Here's the septoparietal band with the infundibulum. This is the left anterior descending that we see down the back here. And you can see the ventricular septal defect as I take these labels away, with the fibrous continuity between the tricuspid valve and the aorta, indicating a perimembranous extension to this ventricular septal defect. And if I can just stop this for 1 minute, as I have here, you can see septal leaflet and aortic valve area with the leaflets in it in fibrous continuity, and the ventricular septal defect, such as in a perimembranous ventricular septal defect, extending into the inlet septum. Here is another such example in case you were worried about it, and what we can do to indicate the defect. Here is the bare area of the ventricle. Oh, excuse me. Just hang on 1 moment. I've just lost it for a moment. Here is the conducting axis here, and here is the ventricular septal defect. Here is the Y of septal band, and there's a deficiency in this area, so the conducting tissue is exposed. There's the conducting tissue, and I'll take it away, and you can see here this fibrous ridge, the membranous flap, which remains, which the surgeon can use to put his sutures in here to anchor this inferior part of the septum and avoid injuring the conducting tissue. And what we can see on echo in this 5-chamber vein is the fibrous continuity between the mitral valve, the aortic valve, and the pulmonary valve. Let me take the labels away for you for a second. And there you can see the aortic root, a so-called 5-chamber view, and the continuity with the valve leaflets lying on the same level. And if we look subcostally in such a patient, in a subcostal coronal cut, we can see this hole in the ventricular septum. So this defect extends into the inlet, as it does in approximately 70% of cases of tetralogy of Fallot. So the valve leaflets are on the same line, they have fibrous continuity, and the defect extends into the inlet septum, and again, the leaflets are on the same level. So that suggests an interventricular communication. Here is another specimen cut beautifully to show you this. Here is the so-called membranous flap. Here is the interventricular communication, and you can see the fibrous continuity between the mitral and aortic valve, which is the hallmark of the perimembranous extension. And this is the right atrial and left atrial appendages, which have been cut in actually perfect 4-chamber view, and compared to the echocardiogram that we see here that shows all of those features, including a beautiful left coronary artery arising off the sinotubular junction. And there's fibrous continuity between the tricuspid and aortic valve here, with no showing of the mitral valve in this region because of the echo cut. But still a good comparison. And once again, lastly, another example of where the conducting tissue runs from the triangle of Koch with the atrioventricular node, and then the bundle running across here, and you'll see the deficiency of the inferior limb here, which occurs in 70% of cases, with this membranous flap still remaining at the bottom end for the surgeon to make his conduction, patch anchoring. And then once again, the atrioventricular valves are on the same level and continuous with the aortic roots. So that's that most important point that I wanted to make. Now, of course, other tetralogies are different. And here in the parasternal short axis, or from a subcostal coronal cut, we can see the differences here. This is the right ventricle has been opened here. Here is the deviated outlet septum, which we're going to concentrate on again. The septoparietal trabeculations narrowing the outlet into the pulmonary trunk. The aortic root behind here. But here you can see there is a posterior muscular ridge here. So here is the Y of septal band, but it's much more enhanced by this posterior muscular ridge. Here's the septomarginal trabeculation. And here you can see that beautifully. Now we can recognize this echocardiographically. And here you will see the posterior muscular ridge that I want you to concentrate on. This is left ventricular outflow tract, pulmonary trunk, and pulmonary valve. When I get to see that in the motion, you can identify that. Tricuspid valve, right ventricle and right atrium, etc. And this is a parasternal short axis cut. And what you can see here, the feature that is absolutely important, is this little ridge of muscular tissue, which is now protecting the conducting tissue. The ventricular septal defect, instead of being in this area, is rotated round here, showing that the inlet septum is intact and this posterior muscular ridge is here. So the defect is now at about 11 o'clock on the watch face, as you would see it. And if you look at the defect in the subcostal view, you can see, instead of a ventricular septal defect here in this 4-chamber view, that there is muscular tissue and that the tricuspid and mitral valves are offset in the normal pattern that you would expect to see them. So this defect clearly has a posterior muscular ridge, and the conducting tissue is now safe from the surgeon's knife. Here is another example showing you that. And here you can see on this defect the Y of septal band with the conducting axis now protected by this thick ridge of muscular tissue that is occurring here. And here is the Y of septal band. And you see this big, thick muscular tissue here protecting the conducting axis. Here, beautifully shown also are the septoparietal trabeculations, which are narrowing the outflow tract together with the deviated outlet septum. And this deviated outlet septum has created the murmur and is also because of the turbulent flow, and that has created a callus of subendocardial fibrosis on the outlet septum when this narrows the inlet into the pulmonary artery. So here we see now the VSD even more rotated round towards the outlet septum, this prominent inlet musculature, and the ventricular septal defect now at 12 o'clock as we look at it on the scan. And there is the outlet septum deviated again with the pulmonary valve down in this region. So these are defects with a posterior muscular ridge, and this occurs in approximately the rest of the 30% of cases with tetralogy of Fallot. So now we'll move down from looking at the ventricular septal defect to looking at the outflow tract and the pulmonary arteries. And the first example I want to show you is this beautiful example from my own archive at the University of California in San Francisco, where the outlet septum is deviated at 90 degrees to the plane of the ventricular septum. Here is the plane of the ventricular septum parallel to your screen, but here you see the outlet tract is deviated completely at 90 degrees. And there's no way that this, in growing down, could come and close this ventricular septal defect. Through the ventricular septal defect, which is the star here, we see the cusps of the aortic leaflet and the cusps or the leaflets of the pulmonary valve. And this malalignment is absolutely classical. That is the central feature that I showed you on the first slide. Now, when we take the leaflets away, you can see the beginning of the movement on this defect here. The outlet septum is highlighted here. Here is the pulmonary trunk over here. The arterial duct is filling as well. And here is the ventricular septum, which is also overriding the defect. But now we're concentrating on the narrowness of this area. And when you add the color flow information on this area, you can clearly see the tight communication here of the severe tetralogy, as well as the presence of an arterial duct. And I will talk about the arterial duct in some detail later on, and the fibrous continuity between the mitral and the aortic valve. So I think a very beautiful correlation. And because of its importance, I'm going to show you another specimen. And here again, you see the scan plane in parasternal short axis view. You see the aortic valve through the scan plane of the ventricular communication, cradled in the arms of the septomarginal trabeculation with the posterior extension, making it perimembranous. The pulmonary valve is seen over here, it's bicuspid. The aorta is not seen, it's arising off here. We could see it a little later when we take the scan colors away. And here we're looking and focusing on the outflow tract. And so you see the deviated outlet septum narrowing the pulmonary infundibulum. The pulmonary valve is domed because it's also stenotic. Although pulmonary valve stenosis is not part of the tetralogy description originally, it is almost invariably present. Here is the thymus capsule with the brachiocephalic vein, the transverse aorta and brachiocephalic artery indicated. And you see how this valve is not moving normally, and the difference in the size between the pulmonary annulus and the aortic annulus. Here is another beautiful example of this with the septoparietal trabeculations, the deviated outlet septum, and the so-called third ventricle that used to be described over here with the pulmonary trunk. And here you can see again a posterior muscular rim. This is an older patient. There's atherosclerosis on this right coronary artery over here. I beg your pardon, left coronary artery. And the perfect correlation between this deviated outlet septum with septoparietal trabeculations noted over here. This is an area that echocardiographically is under-recognized. And I stress that for you so that in future you can help the surgeon by showing him the septoparietal musculature, because this is the area that he has to cut to enlarge the right ventricular outflow tract. Here's the superior vena cava draining into the right atrium and the aortic arch as you see it here above the specimen. And I've zoomed in so that those of you looking on a cell phone can get a better description. Now we're going to look at the length of the infundibulum. Now the infundibular obstruction and its length may vary. Here is a very large area, and you can see also the scarring of the endothelium from the turbulent flow within the infundibulum that has thickened the subendocardial layer. Here's the pulmonary trunk, and here's the tricuspid valve. So a long area of extent, as you see here on the echo. I think this is really kind of self-evident and really not of really great importance, but you can identify that. Then it may be shorter, as we see here, a little bit shorter than in the previous example. And the shortest example over here, there's the ventricular septal defect. And you see how small the infundibulum can be, but it's still tetralogy of Fallot. And this has, again, the beautiful doming of the pulmonary valve, which can be seen as well. Now, when the infundibular septum is incomplete, we have a VSD which has a reminiscent features of a doubly committed and subarterial ventricular septal defect. And here you can see that there is fibrous continuity between the pulmonary valvar leaflets and the aortic valvar leaflets. Here's the ventricular septal defect. And this is the front half of that slice showing over here, again, the ventricular septal defect. the left and right ventricles, and also the aorta and pulmonary arteries. And what I want you to see here is the fibrous continuity between the leaflets of the pulmonary valve and the aorta without any infundibulus septum. And of course, this begs the question of whether this is really tetralogy, because it doesn't have all of the 4 features. But everything else is pretty typical. And this is important because it occurs in people of Asian background, such as the Native American population, which walked across the Bering Straits in the Ice Age, carrying with them their genes, not their Jordache and Levi genes, but their DNA genes for this condition. And so this is a more common condition in Asia, in parts of Asia, than it is in the rest of the world. And it caused Dr. Eldar Castaneda to call this the Mexican Tet variety, as he operated on 3 children from Mexico in one day, all without an infundibulus septum. And the importance of this lesion is the fibrous continuity, which I think you can see here. I've added a little color flow to show that the pulmonary valve leaflets are still abnormal in this condition. But more importantly, if you're working in a center where there isn't access to immediate surgery, this is a kind of tetralogy where a balloon valvuloplasty may give you some temporizing for surgery at a time where the infants are a little bit larger and easier to operate on. So a beautiful example of a Mexican Tet, and I have another one here to show you. Here is the pulmonary leaflets and the aortic leaflets in fibrous continuity. Here's the fibrous trigone of the aortic valve. Here is the interventricular communication, which has a perimembranous extension with mitral and tricuspid fibrous continuity as well. And here is the echocardiogram, and let's just concentrate on the outlet septums over here. And here you can see, here is the pulmonary trunk, here is the aorta, there is no muscular tissue here, and the leaflets on fibrous continuation, one with the other. And I'll zoom in so that you can get and appreciate that perfect echomorphological correlation. Now let's look at the pulmonary valve. And we've taken this heart, the ventricles are up here, the great arteries are down here. We've cut a slice in the anterior aspect of the leaflet of the pulmonary trunk, and we're looking down on the pulmonary valve from above, as the surgeon might do if he opens the pulmonary artery. And you can see here a bicuspid valve over here with the leaflets crossing across the outflow tract. That's an unfavorable sign if a transannular patch has to be placed over here. We'll get to that in a moment. And here is a transesophageal echo taken at this plane over here and showing the doming pulmonary valve, the poststenotic dilatation of the main pulmonary trunk from the jet hitting this area, and the origin of the left pulmonary artery. This is a fairly sizable pulmonary artery. Here is the deviated outlet septum narrowing the infundibulum, but now we're concentrating on the domed pulmonary valve, which is part of the features that you will have to encounter and display and define as an echocardiographer. And here's another heart, which is cut in a front opening. You can see the right coronary artery and the size differential between the aorta and pulmonary artery, as well as the pulmonary valve, and marked infundibular narrowing, as we see over here. And here you see the sizable difference, as we've shown here, between the aorta and the pulmonary trunk. And you can see little aspects of the leaflets of the pulmonary valve in this diminutive pulmonary artery. Probably this is small enough that a conduit would clearly be considered, or a big transannular patch with all of its attendant problems as well. So here is a tricuspid pulmonary valve in tetralogy. Just in case you didn't think that occurred, it occurs in about 20% of patients. And you can see the rolled, thickened leaflets with the 3 commissures that are present here, and the 3 leaflets of the valve in parasternal short axis. And here you see it. We'll take the leaflets away. And here on the echo, we see this. Now, I must tell you that in order to see the pulmonary valve leaflets, because of the rotation of the heart and the right ventricular hypertrophy, the pulmonary valve actually is deeper in the thorax than it is in the normal situation. And so in order to see it, you have to bring the probe up a little higher and turn it in a more clockwise direction to see this kind of valve or leaflets. So you have to not go in the standard parasternal plane, but come up almost underneath the clavicle, rotate the probe round and inferiorly, and you can get pictures like this in a large percentage of patients with tetralogy of Fallot. Here is a bicuspid pulmonary valve in a favorable position. As you see, if the transannular patch was coming across here, the surgeon could preserve the leaflets and preserve a semblance of pulmonary sufficiency. And of course, we know that the largest problem in this condition is the pulmonary insufficiency in the long term. And at Stanford, Professor Hanley has taken these vessels after he's done a tetrapair, and the valve grows, and he has then taken the gusset out and re-established the efficiency of the valve leaflet with little pulmonary insufficiency in a number of patients. So here is an echocardiogram showing the bicuspid valve, but in this case, in a very unfavorable position, because here, if a transannular patch has to be placed, you'll destroy the anterior leaflet of this bicuspid valve. And bicuspid valves occur in over 60 to 70% of patients with tetralogy of Fallot. So that's an important figure. And of course, it's important to be able to define the pulmonary valve for the surgeon, because not that he won't see it in surgery, but this provides him with an opportunity for planning rather than immediate direct observation to change his plan. Now, here is a heart from the archive in Calgary that I have obtained, and this shows a bicuspid valve from the right ventricular outflow tract view. Here's the ventricular septal defect. The right ventricle is hypertrophy and opened in this direction, and I've transilluminated the valve from above with the flashlight, and here is the echocardiographic equivalent of this in a subcostal coronal plane. And you can see very beautifully here that the valve leaflet is truly a bicuspid pulmonary valve leaflet. And here is the aorta coming out and crossing and keeping the pulmonary valve in its inside of its crux. Now, in 10% of patients or so, the pulmonary valve leaflet looks like, almost as Dr. Hanley calls it, a volcano. So you can relate this to any volcano that you see. And you see here the pulmonary trunk is opened. Here's the pulmonary valve. You see this little fibrous ridge that exists on one area over here. And the right ventricular outflow tract has been opened to show this leaflet here. And here is such an example of a volcano valve. And you see the valve is open, is free. There's no attachment here. There seems to be one attachment in this region here. And of course, if this needs to be incised, it does to interfere with the integrity of the valve. But as you see from the size of this over here, the surgeons can put a Hegar dilator in this and dilate up this annulus reasonably well, so that they don't need to destroy the valve if it fulfills the criteria for putting a Hegar dilator in the pulmonary valve to a certain size compared to the tables that they have in surgery and then the valve leaflets are left alone, as it was in this case. Now we're going to talk a little bit about tetralogy with absent pulmonary valve, and this is one of the big misnomers, because the pulmonary valves are not absent. They are merely rudimentary leaflets formed in an annular fashion at the ventricular arterial junction. The combination used to be thought to be primarily associated with absence of the arterial duct, which occurs in a percentage of patients, but in other patients there is definitely ductus tissue, and that is important because when you see the ductus tissue, you cannot assume that this was the cause of the defect. And let me remind you that in even tetralogies, normal tetralogies, the ductus is absent in 30% of patients at birth. So the problem with this combination is the huge dilatation of the pulmonary arteries, which extend well into the pulmonary parenchyma and erode the tracheobronchial cartilage. And I'll show you this in a series of patients. Here is a subcostal coronal cut showing a narrowed annulus with the rudimentary formation of the valves and massive poststenotic dilatation of the pulmonary arteries. The right pulmonary artery has the same dimension as the aorta, the left pulmonary artery as well. And here you see the trachea enclosed and obstructed by these pulmonary trunks. And here is an echocardiogram that shows the same features. There is the aorta, here is the pulmonary artery, and here in the pulmonary trunk and the branches are larger than the ascending aorta. Here's the right atrium and right ventricle. Here's the outlet septum, a good old friend. And we'll zoom in on that for a moment to let you have a look at that. There's the outlet septum once again. Here's the interventricular communication. And there's the ridge, and you can see that there is valve or tissue here. So to call it absent pulmonary valve is wrong. It's really absent formation. And again, another misnomer that has confused people for generations. Now here is an absolutely exquisite example of an absent pulmonary valve from Diane Spicer's archives. You have parasternal short axis and a subcostal coronal plane. We'll take the leaflets off and we'll look at the formation or the absence of complete formation of this annular ring of valvar tissue that exists within the right ventricular outflow tract. Here is the outlet septum, the moderator band, and septoparietal trabeculations. And here, distal with good muscular protection, is the interventricular communication over here, very nicely seen, as well as the tricuspid valve. And when we look at this echocardiographically, we can see that there's a ridge of tissue here, a little bit more inefficient than here, and that this is both stenotic because it's formed and insufficient because it is not completely formed. And here you see the pulmonary trunk and the right ventricle. Here's the ventricular communication. There's the posterior muscular rim here. This is rotated round on the clock from the position of a perimembranous VSD. And what I want to bring to your attention is the so-called, what I call the dish rag phenomenon, or a handkerchief. If you just move it up and down in your hand, this is what you see. You see systolic obstruction and diastolic insufficiency. And let's just do that for a moment. Let's let it play, and let me do this. Take the leaflets off, and we can see this here. Watch the ECG up here. Here is the black and white image showing this little ridge of tissue. And then when we get into the color flow system, you'll see here systole, and there's the stenotic signal across the valve with the proximal isovelocity surface extension, and then in diastole coming back into the valve. So let's let that play. And now let's look at the parasternal short axis, and you see this is, there's the AV valve tissue ring over here, which is both stenotic and insufficient. And we'll just zoom in on that for a moment and let you look at that in filling all of your screens on your phone. Here's another beautiful example showing a parasternal short axis equivalent. Here's the sinus of Valsalva. Here's these little ridges of tissue, which are the pulmonary valve remnants, which have not formed completely. And here is the echocardiogram. And the reason I put this one on is not only to show you this ridge of tissue, but normally it's the right pulmonary artery which has the direction of flow in it. But in this patient, there's been a change, and there's been a directional flow change going almost exclusively into the left pulmonary artery, a so-called Coanda effect of the Doppler color flow tissue. And I put this on here just for a reason, to show that in the fetus, the pulmonary insufficiency is much higher in velocity because of the restriction of flow in the resistance vessels of the pulmonary circulation. But after oxygen is given, the pulmonary insufficiency decreases because of the fact that the vascular resistance is lower. So you see those features that are present there. And once again, a beautiful look at this concept that you should now have of what a supposedly is an absent pulmonary valve. And I think the title should be in inverted commas. But here's the real crust of this disease, and that's this CT scan, which shows here the tracheobronchial tree with these massive pulmonary arteries enlarging and compressing various parts of the windpipe. And you know that the reason why you breathe in with impunity is because the cartilage in your tracheobronchial tree prevents collapse of the airway in inspiration. But in this condition, this is the real problem, because it erodes the tracheobronchial cartilages. And when these patients cannot breathe by themselves, they have prolonged course, and the airways are a problem that require surgical attention as well. And here, these massive pulmonary arteries can be seen subcostally over here. Look at the size of the right pulmonary artery is larger than the aorta. And here from the suprasternal notch in the suprasternal coronal cut, you can see the transverse aorta and the branch pulmonary arteries, which are massive, going to the hilums of the lung. And we'll zoom in on that now for you to get one look if you're happen to look on a cell phone on this particular copy. Now we'll move into the branch pulmonary arteries, and we'll see the right and left pulmonary arteries on this 4D flow signal. We can see them from the suprasternal notch here on echo, and we can see the cut going into the right and left pulmonary arteries. And here the pulmonary arteries are seen to the hilum of the lung. Now, I don't know what the protocol is in your hospital, but when I was in practice at Stanford, if we could see the pulmonary arteries to a reasonable size in the pulmonary arteries, the patients were sent to surgery without any intervening cardiac catheterization. And there's so many other techniques that you can do to look at the pulmonary arteries as well, should you need to do that. Now, here's an example of 4D flow in color showing stenosis of the origin of the left pulmonary artery because of the angulation of the pulmonary trunk to the right side. And branch pulmonary artery stenosis is a problem. I think that the 4D flow shows us very beautifully what we've seen before, is that the flow that's coming out the aorta is not only moving in one direction, but is spiraling as it is moving towards the heart, away from the heart. And here is the echocardiogram, and you see on this echocardiogram stenosis of the origin of the branch pulmonary arteries. And I've shown this only with a color flow system here. We've put the color flow on the two-dimensional image. The pulmonary arteries look actually not too bad here, but when you look at the flow, you can clearly see that there's an origin of flow problems here, and this is something that the surgeon is going to need to attend to. And now, of course, the last thing that's important is that you identify the coronary arteries. And here is a parasternal short axis view showing this on two echocardiograms. And you can see here the left coronary artery here, which the left anterior descending coming behind this open pulmonary trunk. And this, I think, actually defines what the issue is, because if the surgeon has to do a transannular patch and the artery is running over here from the right, that you cut this coronary artery, you're in serious problems. So here's a CT scan that shows the beautiful origin of the coronary artery behind the right ventricular outflow tract. This is the freestanding part of the right ventricular outflow tract. Here's the right coronary artery over here. And this artery is safe from the surgeon's knife. And here is an echocardiogram that shows not only the left anterior descending coronary artery, but also the great cardiac vein. And if you stop, we'll just take the labels off. So this is great cardiac vein and the left anterior descending coronary artery. And if I stop this, you can see that the flow in the coronary artery is only diastolic, and that the flow is, here is the red flow for prograde flow, which shows the coronary artery behind the right ventricular outflow tract. And that's in a normal patient. And here's a patient with tetralogy. There's the pulmonary trunk, and here comes the aorta behind the pulmonary trunk. So the main coronary artery is safe from the surgeon's knife. And this is the problem, because here is the origin of a solitary coronary artery from the right sinus of Valsalva. This patient had a tetrapair with a homograph placed over here because you couldn't cut through the right ventricular outflow tract. And here runs the coronary over the front here. And this is easy to see. It's rare, but this is the important issue. So when you look at the coronaries, you can show the surgeon that the coronary artery is safe, or you can also show him that the coronary artery is going to be a problem. And there are many other techniques besides echocardiography to look at this specific problem. Now, lastly, associated defects. Here is the second muscular ventricular septal defect. Here's the normal ventricular septal defect of tetralogy, and a second defect, anterior defect, a really difficult defect for the surgeons to close. And the embarrassing thing is, you close this VSD after surgery and you find when you do the transesophageal echo that there's an additional ventricular septal defect. And here's another example of a muscular ventricular septal defect back, because here's coronary sinus at the back of the ventricle. And we've all missed them with no matter angiographic or echocardiographic techniques, because the defect tends to go through the bigger hole because it's got a lower vasoresistance. So these often not seen, and one of the advantages of transesophageal intraoperative echocardiography. Okay, so here is the inlet defect here and the outlet muscular defect here. Here's a patient, a fetus in fact, with tetralogy of Fallot and an AV septal defect. This was invariably a Down syndrome, another chromosomal anomaly that occurs with tetralogy type lesions. And almost invariably, this is a type C of Rastelli interventricular communication. Here's the bridging leaflet posteriorly. That's the interventricular communication here. Here's the aortic root with fibrous mitral aortic continuity. And the anterior leaflet is coming across this ventricular septal defect, but unattached to it and attached to papillary muscles within the right ventricle. And you see this long infundibular structure with a very tight stenosis and with a relatively pristine valve in this fetus. Now, I put two pictures over here on this one. Here we're looking at the ostium primum component of the defect. And here is the AV canal coming across into the other ventricle. Here's the ventricular septal defect with the deviated outlet septum and the right ventricular outflow tract. And I can show you that specimen here. So there's the VSD, there's the deviated outlet septum, septoparietal tuberculations, and the complete AV canal. And I have another picture to show you that from the same patient, you can see the ECGs, and these were obtained upside down. So I've turned this up so the ECGs are actually running backwards. So the orientation matches what you see here. And here you see the left ventricle, as the surgeon might look at it. And here you see the anterior leaflet straddling across the ventricular septal defect and inserting in a papillary muscle in the right side. And let's just stop this as we can do that. There's the so-called cleft, which is really the commissure between the superior and inferior bridging leaflets. And there is the chordae tendineae, not attached to the ventricular septum, attached to a papillary muscle within the right ventricle, and there is the rest of the septum. So we'll let that go into play, and we can zoom that up for you so that you can see that once again. So tetralogy with a AV septal defect in an infant with Down syndrome, which probably was the reason for us being able to obtain this specimen, was termination of pregnancy. And here is, again, the echocardiographic pattern of a AV septal defect. You can't see the tetralogy in the specimen, but here in the echocardiogram, you can see the large aortic root overriding both ventricles, and this is the common valve which straddles across, and this is Rastelli type C because it's not attached to the crest of the septum. And we'll remove that so that you can see the leaflets and zoom in on it so that you can get a better look at that over here. So overriding aorta, narrow infundibulum, a complete AV septal defect, bridging across the canal and inserting into papillary muscle in the right ventricle with a nice huge ventricular septal defect. Okay. Now, lastly, we have to think of the arterial duct. And the arterial duct is important because it has connotations, whether it's left or right-sided, and whether there is other defects such as the diverticulum of Komarow associated with it. Okay, and here is such an example, as you see here, aorta. I'm getting to the end of the session. We'll be done in a few seconds here. With this is a right aortic arch with a left brachiocephalic and the arterial duct coming in, supplying to this atretic pulmonary valve a duct here. So there you see a sole source flow through a left duct with the right aortic arch. Okay, and this is a so-called diverticulum of Komarow situation. And here you see the descending aorta and the pulmonary artery filling exclusively from this area here. Subcostal coronal cut. And when you look at the position of this arch, you can see that this occurs in fetal life. And in fetal life, the pulmonary blood flow is, should be coming through the pulmonary artery, and the ductus arch should be in this plane. But you can see here that this ductus arch is in a vertical plane over here, because all of the flow is coming around and into the pulmonary artery to supply this pulmonary artery there. And so you see the arch with a vertical duct and the pulmonary veins and left atrium cut across in this beautiful cine CT from Dr. Tony Lavacek. And here I've oriented the echo exactly in the same plane. So you see the aortic arch, and you see the vertical orientation of this ductus with this sort of a meandering pattern down to a pulmonary trunk, which is has no prograde flow into it. It's all from the duct. And your vertical orientation is assured. I'll take the labels away from you, and I'll zoom that up as much as I can to show you this area and how beautifully it can be highlighted with color flow imaging. Now, I think you have to always recall every time you examine a small patient with a tetralogy that there's a duct, because the duct could give you a false sense of security of the significance of the severity of the tetralogy. And when the duct closes, the patients who have been supplying even a small amount of blood flow will lose this and can become instantaneously severely cyanotic and become surgical emergencies. So always look for the arterial duct. Here it is subcostally coming off here, and in the same patient, you can see this duct from the parasternal short axis view. And then, of course, here's the right aortic arch, and I like to orient my right aortic arch in a suprasternal coronal equivalent view. And here comes the ductus around the from this right aortic arch around the trachea and join into the pulmonary trunk. Here you can see the right aortic arch with the first brachial cephalic vessel being shown over here. And then you can see also that this goes to form the ductus entering into the left pulmonary artery. So there's an arterial duct for you with a right aortic arch and left-sided ductus. Now, I'm going to skip through this because of the time. And of course, this is available through my website that I've given you earlier on to show you this. And I will be glad to try and take any questions that I have on the subject now. Thank you very much for your attention.
Thank you, Norman. I think that there is no more secret about the technology of Fallot. And I would like to ask to all the people who is interested to make some question, they can type the question in question and answer section. So there is a first answer, but I don't read them. I would like to share with you. There is Alejandro Lozano who is asking that in the echo parasternal short axis, before the began to talk about the tetralogy of Fallot with the pulmonary absent pulmonary valve, there is an image that is emerging from pulmonary trunk, and the question is that a coronary artery or what is this structure? I don't know if you remember the.
I don't remember it. I can go back and have a look at that.
Yes, is the one before you start about tetralogy with the absent pulmonary valve.
Absent pulmonary artery?
Yes,
okay.
As absent pulmonary valve.
Okay, I'm going to look over here.
Yes, there is a view that he said that you see about...
He's asking about this little structure here, is that right?
Yes.
Okay, I just think that's part of a fibrous ridge. That's not pulmonary artery, not coronary artery. Okay? It's part of a fibrous ridge.
Oh, okay. And there is now a new question from Jason Tan. He's asking about perimembranous VSD and mitral and tricuspid, if they are at the same level. What this is described as inlet VSD?
Well, it's in the membranous septum. I mean, here's the issue that if you've been following the Congenital Heart Academy, Professor Anderson has been talking about the essential features of a membranous ventricular septal defect. And the membranous defect, the essential feature is that the membranous septum is closed by tubercles that occur on the primitive AV canal defect, the primitive AV valve, and also by an extension of tissue from the outlet septum, okay? And so the defect in tetralogy often has this here, and I'm sure, Sasha, you can confirm that, you know, you have to be careful of the conducting tissue when you're dealing with this, because, I mean, heart block is a real problem after tetralogy repair, and you don't want a pacemaker. So I think that this is the important area. And when you get this attenuation here, in this region here in tetralogy, everybody can see these pictures. Let me just...
Yes, you can go...
I'll just put it... I'll just put it in... When you see this pattern here, it's this area over here where the tricuspid valve then is continuous with the aorta and the pulmonary trunk, because there is mitral aortic continuity, but there's also now tricuspid, aortic, and mitral continuity. And this is the area of the membranous septum, which is formed by the tubercles of the AV canal and a contribution from the outlet septum that closes the ventricular septal defect. So the defect is not really membranous. The defect is, excuse me, the defect is a perimembranous, not really an inlet defect. Of course, if the defect is large, it can extend into the inlet septum. So I hope I've answered that question with this diagram, as well as with many of the pictures that I've shown.
So there is a question from Ogo, who is a pediatric cardiologist from Nigeria that is in the congenital heart delegates. So the question is, Norman, can echocardiography alone suffice as the preoperative imaging modality for intracardiac repair of tetralogy of Fallot, or is additional imaging such as CT scan, and why would CAT be necessary from as part of MAPCAS embolization? Avanti.
Well, I mean, I think that's a very interesting question. And I think that the person that asked that has got to look at the issues and resources that they have and the quality of their echocardiography. I think that the most important issue, Sasha, in this answering this question is the ability of the echocardiographer and the ability of the surgeon and the trust that develops between the surgeon and the echocardiographer about this defect. In 2001, we wrote up a number of papers of successful surgery without tetralogy, without cardiac catheterization. And I think that it's possible to do this, but I think one has to always look at the whole global issue of the ability of the surgeon and the echocardiographer, the trust that they have, and also what resources are available to the institutions. Many institutions are somewhat limited in the use of magnetic resonance or CT, in which case maybe even if there is any suspicion of abnormality that is unusual, I would go for a catheterization on these patients. I think sometimes now with MRI and CT, provided you get to these patients at a reasonable time, you can operate on these patients with the trust that we have established at both the University of California and Stanford University, where I've worked during my career, with the surgeons, and feel very comfortable about the fact that the surgeon is not going to have any surprises when he is in the operating room. Yeah. And I think that's the important issue. So I think it's possible to do. It's really institutional basis, bias, etc. And I can't answer for what can happen. When I present the patients to the surgeon, who always comes to examine the echocardiograms, I tell him what I think is the issue and whether I think that he can operate on this patient without going to additional tests or not. But that's always the question you have to ask, and I can't answer it for Nigeria. I can't answer it even for Las Vegas, Nevada. And that's the state that's next to mine. So it becomes very difficult for me to give, especially with a surgeon that I don't know and who doesn't know my ability. You know, I mean, surgeons have to protect themselves. And today, many young surgeons are insisting on CT scan and MRI because they've grown up with it. So I think that it's a difficult question to give a straight, direct answer, and it's basically related to the kinds of defects that you get.
Okay, there is another question from José Augusto Barbosa, who is asking about your experience with the tetralogy of Fallot and absent patent ductus arteriosus.
This is, Sasha, this is a question that you can answer, because let me just say that at my institution, the preferred time for operating on tetralogy, despite what has been published in the literature from Philadelphia, is to do a primary repair. Now, many people with tetralogy will consider basically doing a shunt and then waiting for some period of time. And there are pros and cons which I cannot answer in the time that's available for me now. But we do our operations at between 6 weeks and 12 weeks. And when you operate on a patient with any patient to do cardiopulmonary bypass, one of the primary things you have to do, and in fact, in every patient under a year of age is done in my hospital, is to ligate the ductus. So in other words, you have to find the ductus and you have to put a clip on it. Otherwise, you can't do good pulmonary bypass. Isn't that right, Sasha?
Yes, I think
so.
that
You would know when you operate on a small patient and there's no ductus, especially early on, that there really wasn't a ductus. And let me point out, if you look at the conotruncal defects, by and large, for tetralogy, truncus, double outlet, and absent pulmonary valve, and even some cases of transposition, that there is no arterial duct in these patients. And we know that all of those things occur. So they occur in this group because it's part of the second heart field contribution, and there are plenty of problems in that area. So we know that there is no ductus in a percentage of tetralogies, and Dr. Hanley insists on telling me that in his series, it's 30%. I've not seen that issue, but I think what we need to do is start looking at this with fetal echocardiography to see what percentage of fetal patients don't have an arterial duct.
Yes.
But this is a primary abnormality.
Okay. So there is a very good question, I think, from Sergei Filonenko. This is something very interesting. Do you were able to calculate the Nakata index using echo data?
I have not had that problem. You're talking about for TET pulmonary atresias?
Yes.
No. Well, certainly one thing for sure. TET pulmonary atresia, unless there's a sole source ductus flow into reasonable sized pulmonary artery, is going to trigger a variety of accessory tests, such as CT or MRI. Primarily CT, because in young patients, CT is quicker and much better, and these are often sick infants. So you have the CT, and you can do the Nakata or any other index about the size of the pulmonary arteries based on that issue. And also, in the absence of pulmonary atresia, if it's very severe and the pulmonary arteries are not of good size, that would trigger a different test for me right on. So I have not had that experience of having to calculate the Nakata index or a Magoon index on the basis of echocardiography.
Yes. And now I think is another good question from Andriy Kurkevich, who is asking for you if you can make a difference between tetralogy of Fallot and VSD pulmonary stenosis settings.
Yeah, I think that the hallmark of the tetralogy is the anterior superior cephalad deviation of the outlet septum, and valvular pulmonary stenosis with VSD is a different animal. I think completely different animal.
Because also the conal septum is
well, that's the conal septum. You know, we've used here, as you see on this picture here. You're still seeing my picture?
Yes, yes.
Okay, well, here's what this is called. We don't call it the conal septum, but there it is. This is the conal or the infundibular septum or the outlet septum. Okay?
Yes.
I mean, and it probably is of conus origin. If you followed Professor Anderson's talks on the Congenital Heart Academy, you will see that this is the conal septum that grows down in the spiral fashion and is part of this malalignment. So this is the fundamental of what goes wrong in tetralogy of Fallot. So valvular pulmonary stenosis and ventricular septal defect is physiologically similar, but is anatomically different.
Very good. So I'm sure that you have time for one last question. It's about
Sure.
Jason Tan, who is asking if you can make a sort of difference between supravalvular pulmonary stenosis and doming valve tending to do supravalvular stenosis.
Yeah, I mean, I think that's a good question, and I maybe didn't deal with it sufficiently. The issue is, of course, that we look at the pulmonary arteries, we see doming. When you see the doming valve, there's often poststenotic dilatation. But in dealing with pulmonary stenosis as an entity, we're talking about the valvar leaflets. We talk about also the sinotubular ridges that we see over here. And there's often constriction in this region. So you can get a valvar stenosis with supravalvar restriction, and then you can also have supravalvar stenosis. I think in tetralogy, it's largely a restriction at the sinotubular ridges that causes a supravalvar stenosis. And I think that's inherently part of the valvar pulmonary stenosis. And indeed, I mean, when we look at looking at the success of balloon valvuloplasty in isolated pulmonary stenosis, the patients that have restriction at the supravalvar area seem to make a less effective result from balloon valvuloplasty than the ones that don't have restriction at the sinotubular ridges.
Okay. Thank you very much, Norman. It was amazing. I think that we will see soon with a new appointment with you, and we will see on Friday with Bob.
Yes, sure. Well, anyway, yes, keep on following the sessions, and I wanted to thank all of the participants for their keen following, and also for the brilliant questions that are answered. And although, Sasha, you said that, you know, there are no problems left in tetralogy, there's still, when you think about it, there are issues that come up that we still haven't solved the problems of. And I think that's the beauty of revisiting something that is apparently simple and taken care of. And I think Bob's Friday sessions bring that to mind every day we look at them, that there are problems that we haven't been able to solve. And also for the participants, that there are problems that are really quite beyond what we have seen over here. So I thank you very much for allowing me this wonderful opportunity to look at the correlations between pathology and morphology. From my own point of view perspective, I look at the echocardiogram and see the pathology in my mind, but also for the pathologists and the surgeons, they can see the pathology and see the echo in their minds. So I think it's a good for surgeons, anesthesiologists who are working in the area, in the operating room, cardiologists, pathologists, adult congenital people, and so on and so forth. Okay. So thank you very much for this opportunity, Sasha. Ciao.
Thank you very much. See you from all over the world on soon with Professor Sievelman, and then on Friday with Professor Anderson. Congenital Heart Academy, thanks all of you to be with us.